Thank you for joining us for the 4th Annual Global Summit on Kidney Innovations. Global Kidney Patient Voice, the key to accelerating innovation. A collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Kent Bressler, and I am an AAKP Board of Director, an AAKP Ambassador for the state of Texas, and host of the podcast series, Kent's Kidney Stories. In addition to being a veteran and a retired nurse, I have also been a kidney patient for over 45 years, and I'm grateful to have received a preemptive kidney transplant 35 years ago on April 30th, 1987, from my brother Kip. His donation allowed me to receive a transplant without ever having to go on long-term dialysis. That, personally, is one of my hopes for all of those who are suffering from kidney diseases, to transplant first. I am forever grateful for the selfless gift my brother has given me and for the love of my family through the grace of God. As co-founder of a 501c called Kidney Solutions, a network of transplant experience, our all-volunteer agency provides mentoring services for all those seeking a living kidney donation, and all our services are free without any fees. I have worked closely with the members, the staff, and the executives at AAKP. It has also been a pleasure to podcast many of the kidney warriors who are members of AAKP, and I have actively been involved with the AAKP Veterans Health Initiative. My love of helping those with kidney disease has been strengthened and enhanced by friendships I have made with the AAKP membership. Being part of AAKP allows me to stay focused on the patient with kidney disease and their families. There is always someone there to help you at AAKP. I encourage everyone to join AAKP. Membership is free and will help you to focus on the most important part of kidney disease, and that is the patient. It is critical now that we as patient consumers raise our voices and create the demand for new diagnostics, devices, and biologics in our independent countries. Through AAKP Global, launched in 2019, AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the opportunity to save more lives. At AAKP, we believe that a united patient voice can drive innovation and the policy decisions that determine timely regulation and payment for new and safe care treatments. Globally, we are working with patients, medical professionals, researchers, and medical industry allies to cultivate a united consortium led by patients. AAKP believes this international consortium can advance innovation and change kidney care in countries where healthcare systems and/or infrastructure do not support patient consumer choice and/or access to care and treatment. For this session titled Monitoring the Kidney Allograft in the 21st Century, I'm pleased to introduce Dr. Manikkam Suthanthiran. Dr. Suthanthiran holds a Stanton Griffis Distinguished Professorship in Medicine and Professorships in Biochemistry and Surgery in Medicine at Cornell University Medical College. He is the founding chairman of the Department of Transplantation Medicine and chief of Nephrology and Hypertension at New York-Presbyterian Weill Cornell Medical Center. Dr. Suthanthiran serves as the co-chair of the Executive Transplantation Council of the Multi-Organ Program of Columbia and Cornell, New York-Presbyterian Hospital. We are honored to have him with us today. And Dr. Suthanthiran, I now turn it over to you.
It's an honor and a privilege to contribute to this global summit on kidney innovation, sponsored by the American Association of Kidney Patients and George Washington University School of Medicine. I thank my esteemed colleague, Dr. Dominic Raj from George Washington, and Mr. Paul Conway, co-chairs of this summit, for giving me this wonderful opportunity. Kidney transplantation has transitioned from a high-risk procedure to a safe and life-threatening and life-restorative therapy in a relatively short period of time, thanks to biomedical research. I think it is very appropriate for us to discuss innovations in kidney transplantation in this meeting. This historic slide captures the key participants, the pioneers in the medical miracle of kidney transplantation. Just 2 days before the Christmas of 1954, the first successful kidney transplantation took place at the Peter Brigham Hospital in Boston, Massachusetts. Dr. Joseph Murray performed the kidney transplantation and went on to win the Nobel Prize for his pioneering contribution to the field of organ transplantation. The gift of life was made possible by Mr. Ronald Herrick donating his kidney to his brother, Mr. Richard Herrick. The gentleman standing between the donor and the recipient is John P. Merrill, a nephrologist, chief of nephrology at the Brigham, and considered by many to be the medical father of kidney transplantation. The urologist, Dr. John Harrison, makes up this group of people, these pioneers. And when you think about this, what Dr. Harrison did is really remarkable, that he took a perfectly normal individual for a major surgery and took a kidney. This is perhaps the first time a normal person underwent a major surgery, a donor nephrectomy, not for himself, but for the sake of saving the life of another person. This transplant functioned gloriously. And a very important reason why it functioned was because the recipient and the donor were monozygotic identical twins, that they were completely matched. There was no difference between them genetically, as you might have already guessed by the way they look very, very similar. So there was no foreignness between the recipient and the donor. And this turned out to be the very first successful kidney transplantation. What happens when you do a transplant between individuals who are not perfectly matched? Not all of us have the benefit of having a monozygotic identical twin as a donor for us. So what happens when you transplant a kidney between individuals who differ genetically? This slide shows the first 216 kidney transplantation done worldwide and reported in the early 60s. You will see here that the 1-year survival rate of the patient following transplantation was just 10%. 9 out of 10 kidneys failed. And this happened when the donor was actually a living donor. That's one of the, when you do a kidney transplantation, living donors do so much better than a kidney coming from a deceased donor. So the 1-year survival was only 10%. What about kidney graft survival? Just 7%. So if you do 100 kidney transplants, seven of them are working at 1 year transplant. This was a dismal outcome. The brave transplant physicians and surgeons persisted in that effort, continued to do transplantation, and thanks to advances, we are now in a much, much better shape. Due to improvements in immunosuppressive therapy, due to better control of infection, and very, very importantly, the research, my laboratory and many other laboratories across the world has done, we have now moved to a situation, not 10% of the patients survive, 95% of the patients survive at 1 year. And the graft survival is not, less than 10%, but a spectacular 90% at 1 year. This is, when we talk about innovation, here is innovation, going from 10% survival to 95% survival at 1 year. Less than 10% survival of graft to 90% survival. This is where we are today in the United States, and this is where we are around the world in many academic transplant programs. Can we declare victory at this time? Not at all. Why? We have achieved wonderful success in short term, but when it comes to long-term survival, we are not doing that well. Whereas we are looking at 95% survival at 1 year, when a kidney is transplanted over 10 years, 50% of the transplants fail. This is what happened across the United States. 50% fail. There are not enough kidneys to go around. There is a striking shortage in organs. That's an organ shortage crisis. We'll never have enough organs to transplant. And here we are losing 50% of the transplants within 10 years. The question is, why do transplants fail? The transplants fail because the transplant recipient's immune system, the immune system is the natural defense that protects us against infection and cancer. Unfortunately, perceives the transplant, the life-saving transplant, as an invader and mounts a transplant destructive immune response. And this response is called rejection, and rejection is the major cause of kidney transplant failure. This is exactly the problem my laboratory and many others around the world are focusing on. How to prevent rejection, how to diagnose rejection, how to manage rejection. And this is a major focus of many research laboratories. This slide shows you what rejection is all about. What is kidney allograft rejection? Now, when you look at the kidney under the left panel, the normal kidney, you have what is known as a glomerulus. This is the filter that filters and makes urine. And all the nice surrounding structures are called tubules, and they do an enormous, beautiful job. You may be amazed to know we filter almost 100 liters of urine each day, but we excrete only 1 liter of a final urine product. The kidney is probably one of the most smartest organs in the body. And what you see on the left side is under the caption, normal kidney, looks like this, a nice glomerulus, a number of nice tubules. What happens during rejection? The middle panel is what is known as acute rejection, and this is an area my laboratory has been studying for some time. What you see here, instead of a normal looking kidney, the cells in the immune system, all those black dots, these are cells. They should be living in the vascular tree or vascular compartment. They have left their home, come into the kidney, and tries to destroy the kidney. These are what are known as killer T cells. And these cells are all very important to keep us safe from infection, keep us safe from malignancy. But when it comes to transplantation, the same cells destroy the kidney. And this is acute rejection. You can see all these cells, attacking the tubule, the cells in the interstitium. If you look under the microscope and if you look at them carefully, you can see these are very large cells, and they are in the wrong place at the wrong time. This is acute rejection. And the acute rejection ultimately leads to chronic rejection, that is shown in the extreme right panel. And what you have here is fibrosis. If we prevent acute rejection for a large extent, we can prevent chronic rejection. So this is what we want to prevent. If we successfully prevent rejection, we can now keep the transplant working. So what is our research objective? Each of the research laboratories have one major theme. The major theme for my laboratory for more than 30 plus years is to have one transplant for life. You do a kidney transplant, you do a heart transplant, one transplant for life, and not have the transplant reject, in 5 years or 10 years. You put in one kidney, you got it for life. So there are different ways to accomplish this goal. And what my colleagues and I have done at Cornell, at York-Presbyterian Hospital, is to develop technology, develop molecular tools for accurate diagnosis of rejection. And also to develop treatment protocols that are highly personalized, not one size fits all, but highly personalized for an individual patient. This slide shows what my laboratory has been trying to do. It's not a complete finished story yet. We are continuing to work day in and day out to accomplish this. What do we want to do? In the simplest term, what we want to do, we want to pick the right organ for the right patient. We want to pick the right drugs. We have several drugs we can use in transplantation, but we want to use the right drug for the right patient, and very importantly, give the right dosage. Why right dosage is important? It's important because too much of a drug, even though it's beneficial for a transplantation, can lead to infection, can lead to cancer. So the right dosage is important. So our overall goal, the overarching theme, pick the right patient for the right kidney, pick the right drug, and pick the right dosage. How do we get this done? It's a very big goal. How do we get it done? So what we have done at Cornell is we invented urinary cell gene expression profiling. What is urinary cell gene expression? Right now in 2022, if you want to know what's going on in a transplant, you have to put a needle into the transplant and take a piece of tissue, a biopsy, and examine it under a microscope. We reasoned, instead of doing a biopsy, if we collect urine from a patient, that shouldn't be a problem, but really develop molecular techniques. You take the urine, you spin it down, take the cells. From the cells, you isolate RNA, and through a fairly complicated molecular technique called polymerase chain reaction, this technique invention was resulted in Kary Mullis getting the Nobel Prize. This is one of the major inventions, the PCR or polymerase chain reaction. But what my laboratory did is to move the polymerase chain reaction to higher level. This is what we accomplished. Kary Mullis invented PCR, but we made it better, and we also applied it to profile urinary cells. And the gene expression in the urinary cells gave clues about what is going on in the transplantation. The significant benefit from this approach is you can avoid doing a transplant biopsy. That's a major, major advantage. We can also identify patients who are tolerant, that is, those patients who may not need immunosuppressive therapy. But I must tell you, this is all at a research level at this time. It's my fervent hope that this will be translated into clinical care in the next few years, and that we have been working on this, believe it or not, for almost 20 years. Now I'm going to show you some data how we accomplished it. This is one of my favorite quote. You are a sophisticated audience. I shouldn't make things more simpler than needed. So now I'm going to show you our research studies. This is a paper from my laboratory that was published in a premier journal called the New England Journal of Medicine. We published this paper almost 20 years back, and this is what we have been doing and continuing to do even today. What did we accomplish? What we accomplished and what is summarized in this slide is we measured certain genes in the urine. We measured a gene called granzyme B. We measured a gene called perforin. We invented an assay so that we can measure the precise amount of perforin and the precise amount of granzyme B in the urine. And inside the red box is the actual data from the New England Journal of Medicine paper. These are different conditions. What we are showing here are patients with rejection have a high level of perforin and granzyme B. This was the first time ever anyone has shown that if you measure these two genes in the urine, you can diagnose rejection. So now we have a test, and hopefully this test will become a clinical test. The take-home message from this slide is that urinary cell mRNA profiling offers a non-invasive means of diagnosing acute rejection. As I mentioned earlier, the way you diagnose rejection is by putting in a needle and doing a biopsy, and that's not that easy to do. This is this was in 2001. 4 years later, we published this paper also in the New England Journal of Medicine. This paper was published from my research team. In this paper, what we are showing here is we can actually predict which patient will respond to treatment and which patient will not respond to treatment. Right now, in the clinical arena, we do a biopsy, we look at the biopsy, and the biopsy tells us, maybe this patient will respond, maybe this patient will not respond. But we discovered this particular gene called FOXP3, and the level of FOXP3 gene in the urine predicted who would respond and who would not respond. So we now have a handle about a patient whom we can treat more successfully. The patients we cannot treat more successfully doesn't mean that we don't have any hopes for them. We have hopes for them in the sense that we'll have to create new types of therapy than existing therapy. On the left-hand side, the boxes are called box and whisker plot showing FOXP3 gene is in patients with rejection reversal. The green things are called receiver operator characteristic curves, and these curves tell you at what level you can predict rejection. Almost 8 years later, we published this paper, also in the New England Journal of Medicine. This is the largest urine gene expression study done in the world to date. We studied almost 500 patients. We collected 4,300 urine samples in 5 different academic centers. The urine was sent to my lab. The test we invented, we performed the test. We sent the data to an independent statistical analysis core, and they analyzed the data. And what did we find? What we found here was very unique. One, we confirmed that the patients, we can diagnose rejection by studying gene expression in urine. We confirmed that. We confirmed, and in research is very important, not only report a new discovery, it's very important to validate or replicate. And we replicated that reversal can be predicted by FOXP3. But what's very important in this slide, if you look at that red line, the red line is the threshold you don't want your patient to cross. We found that the patients who develop rejection cross the threshold almost 20 to 40 days before rejection, before you get problem, before you see a clinical problem. Whereas those patients who have an uneventful kidney transplant, their level of urine gene expression remains below the red line, remains below the threshold. The take-home message from this slide is that we discovered a gene signature, and this gene signature predicts future development of acute rejection. This is very beneficial because once the rejection happens, there is certain amount of damage to the kidney graft. So we want to prevent the damage of the kidney allograft by knowing before it happens, and then the clinician can treat the patient. So to capture what we have accomplished today, we have invented a special way of measuring genes in the urine. We have applied this test to diagnose rejection without doing biopsy. We have applied this test to identify which patient will respond to therapy. We have applied this test to identify who is going to get into trouble in the future. We are very, very excited about it. Many in the transplant community are excited about it. And I think this gives an opportunity to change the way kidney transplantation is practiced around the world. The ultimate goal for us in transplantation is drug-free kidney transplantation. That is, you do a transplant, you give drugs for some time, later on you completely stop the drugs. Why is it important to stop the drugs? It's important to stop them because too many of drugs and too long a time can cause all kinds of problems like diabetes, life-threatening infection, life-threatening cancer. So what we want to accomplish is tolerance. This is the holy grail of transplantation, that you transplant someone and you give them drugs for a short period of time, 6 months or 12 months, and then you completely do it. Is it achievable? Can we actually have tolerance, not just in mice or rats in your laboratory, but can you really do this in patients? And the answer is yes, in a small group of patients at the present time. This slide shows tolerance. These are patients who got their kidney transplant at Mass General. Dr. David Sachs was the leader of the research team at Mass General, and my research team at Cornell collaborated with Dr. Sachs's group, and we again used our urine gene expression study and also expression in the biopsy itself to identify what is the molecular signature in this patient so we can identify which patient is tolerant. If we can identify patients who are tolerant, then we can stop the immunosuppressive drug. And not only in this Mass General study, there was a major immune tolerance study that was done. And this slide, again, these are box and whisker plot. We measured genes in the urine of people, and we identified patients who were tolerant by the level of certain genes. In this case was CD20, which is a marker for B cells, FOXP3. All these genes were higher in those patients with tolerance. We also identified few other genes like CTLA4 that could be a marker for tolerance. So this is very, very exciting if we can now bring this and translate it to all our patients, but much research needs to be done. There's no question research is the pathway to accomplish these goals. So I just wanted to go back to the aspirational goal of one kidney transplant for life. Right patient, pick the right kidney, right organ for the patient, right drug from a number of drugs that are available to the transplant clinician. You pick the right type of a drug therapy and very importantly, give the right dosage. How do we accomplish that? One pathway is to use our gene expression test for monitoring the patient and personalize the therapy. Because the gene, as I showed you in my earlier slides, because the level of the gene reflects whether someone is rejecting, you may avoid biopsy. I showed you before that the level of certain genes may reflect tolerance. Maybe we can identify patients who are currently on immunosuppressive drugs. If they have the right molecular signature, maybe withdraw drugs. But all of these things have to be done under a very careful settings. This is my last slide, and it shows one of my favorite quotes. Paths are made by walking. And this is so true for transplantation. We did not have transplantation maybe 60 years back. Now there are thousands of people living a very successful life, a very productive life thanks to transplantation. How do we achieve this? This is not just us doing research. It's a team effort of physicians and surgeons. And it's not just doctors alone, it's scientists, nursing personnel, and very, very importantly, the patients themselves. The patients are the true heroes here who put their trust in our hands. Now, transplantation is very safe. What I would like to do and what my colleagues would like to do is to make sure one transplant for life, not lose transplants after 10 years or 15 years, but have one transplant for life. At the same time, have it be safe and have it highly personalized, right drugs, right transplant, right dosage. And our contribution, and there are many other laboratories who are doing brilliant research. Our contribution is this invention of urinary cell gene expression by refining a molecular test called PCR assay that allows us to avoid biopsy most of the time, that allows us to identify rejection, that allows us to predict who will respond to therapy, and allows us to understand who might develop the problem in the future. And also, allows us to identify patients who could come off immunosuppressive therapy. Clearly, this is an ongoing research. More work needs to be done. And I think in the very near future, some of these things will be in the clinic, some components of it. So this has been a wonderful opportunity for me to share some of the exciting work we are involved in. This is a team effort. Many, many different people are involved. And I would like to thank the American Association of Kidney Patients and George Washington University, especially Dr. Dominic Raj and Paul Conway, for giving me this opportunity to share with you. Thank you very much.
Thank you, Dr. Suthanthiran, for a great presentation. We appreciate you taking your time to share your insights and expertise.